Leg, and I'm from the North Dakota Department of Health. Lindsay, do you want to go ahead?
Sure. Hi, I'm Lindsay Myers. I'm from the Colorado Department of Public Health and Environment.
How about you, Lisa?
Hi, I'm Lisa Roth. I'm the Deputy Director at the University of Iowa's Injury Prevention Research Center.
Okay, and then there's a number that I don't know whose number it is. Oh, is it
Lisa Peterson? I'm also on here. I'm with Missouri Department of Health and Senior Services, and I'm the Injury Prevention Coordinator.
And then,
so that may be me. I don't know.
Oh yeah, I think it is you, because when you started talking, Lisa, then your name came up. So.
Oh, okay.
Great, thank you. Okay. And then Sarah, looks like Sarah's on the call.
Yeah, Sarah Brandspiegel's here. I'm with the Colorado School of Public Health.
Okay. Hi, are you on?
Can you hear me? Oops.
Okay, I'm not sure who that was, but you can go ahead, whoever that was.
This is Tracy Hardy from CDC and also Lindsay Myers groupie.
Okay. Wow, I didn't know I had groupies. That's awesome.
Well, and Mandy, I'm here. This is Peg. I'm Peg Oji Ginsburg. I'm Peg Oji Ginsburg from Health and Human Services in Nebraska. I'm the Injury Prevention Program Manager.
All right, thanks. I think Sasha's next on the list.
Yes, this is Sasha. I'm at the Colorado Department of Public Health and Environment with the Child Fatality Prevention System, and I'm here with a couple of other team members who can introduce themselves.
Hi, I'm Kate Jankowski, also at the State Health Department here in Colorado with the Child Fatality Prevention System.
And then one more moment. It's coming around.
Hi, I'm Andy Wooster. I'm the Data Visualization Manager here at CDPHE in the Violence and Injury Program.
Hey.
We're also Lindsay Myers groupies.
Oh, God. Let's be Colleen's groupies.
You're also Colleen.
I feel like we should get a T-shirt, Lindsay, that says groupies or something.
I agree. I agree.
Okay. Let's see here. I think I saw Celeste's name on here. I think.
Hey, yep. This is Celeste from Nebraska as well. I work in the EPI department, but do a lot of work with PEG and injury prevention as well.
Thanks. And then I think we have Dana.
Hi, this is Dana Zulk. I'm the Section Director for Injury and Violence Prevention Programs at the Kansas Department of Health and Environment.
Okay. And then I think I did see Dwayne's name too, but it left screen.
Hey, it's Dwayne Smith, Children's Hospital Colorado Injury Prevention Program Manager, and I have no groupies, sadly.
I'll be your groupie, Dwayne.
I'll be your groupie too, Dwayne.
Thanks for the assist.
Okay, and then I'm not sure, there's one number that I don't recognize, maybe somebody joining on the phone.
Yeah, this is Keisha Henson. I'm the project officer for Colorado from CDC.
Okay, great. Okay, and then I don't know, Lindsay, did you want to make an announcement about Colleen?
Sure. As you can see, I'm sorry, you probably see that too. Renaming Keisha for a minute. This is Colleen, who usually facilitates these meetings. Had her baby last week, so this is Colleen and her husband Ryan and their new baby Devin Michael. So I just thought I would share with you all. She's doing great, and we will try to keep things together while she's gone. She's left me a big to-do list. So, I know I have lots of other people on the phone who are helping out. So thanks for that.
Okay. And then I'm sorry, is there anyone else that's on the phone that or joined the meeting that I may have missed? I guess I should have asked that before we did the Colleen sharing moment. Okay. All right, then I think we'll go ahead and get started. I have my colleague Clint Boots from the North Dakota Department of Health, and he is an epidemiologist, and he will be discussing the North Dakota Multi-State Electronic Health Record-based Network for disease surveillance, also known as the MENS project. So take it away, Clint.
Let's see, we can't hear Clint if he's talking. Is he sitting with you?
Yeah, I got to get right in front of the computer here.
Yeah.
Okay, can you hear better now?
Yes.
Okay. Again, I'm Clint Boots. I'm an epidemiologist with the North Dakota Department of Health. I work with the Heart Disease and Stroke Prevention Program and the Tobacco Prevention Control Program. What I'm going to talk about here for just a few minutes, it really just rose out of just kind of a casual conversation Mandy and I were having one day, and I started describing to her about the NDS. Before I get started, I guess I'd like to ask, has everybody or anybody heard about this project before, or? No? Okay, well, then, that'll be good. I won't be going over stuff that people already know.
Hey, Clint, I hate to bother you again. You kind of are in and out, so I'm wondering.
Oh, okay. I was wondering, has anybody heard about the multi-state EHR-based network for disease surveillance yet?
I know it's new for me.
Okay. Well, yeah, I just thought it would be good if I'm, not boring everybody going over stuff they already know. But I should start with a little background on it. And it started in 2018. The CDC funded the National Association of Chronic Disease Directors to issue a funding opportunity for 2 states. And these 2 states would be funded up to $165,000 each to participate in a pilot project to establish an EHR-based chronic disease surveillance system. This system is called, as we've said, the Multi-State EHR-based Network for Disease Surveillance, or MENS. And this sort of system has been used successfully in Massachusetts. And then Maryland, the Maryland Department of Health and the Washington State Department of Health were selected from 18 states that expressed interest, and their pilots began in January of 2019, so just a little while ago. However, North Dakota got involved with this because we did express interest in joining the project, but we weren't quite ready to embark on being a pilot state right away. So we were selected to shadow Maryland and Washington because we are well situated to become a pilot state in the near future. Mainly there was a big data system update or upgrade that the North Dakota Health Information Network was undergoing, and that made it so that we couldn't embark on being a pilot state right away in January. Another thing I wanted to say is that the National Association of Chronic Disease Directors will continue working with all interested state health departments to prepare them to participate in the MENS project as funds become available. A little bit of information on the MENS project itself is that it addresses privacy concerns with using EHR-based data by employing a gatekeeper model in which raw data is stored behind the data owner's firewall and only aggregate information is released to health department users. The North Dakota Health Information Network, or NDHIN, of course, as I mentioned, is partnering on this project, and of course it couldn't happen without them. And the NDHIN's centralized role as a statewide health data repository is, that should greatly aid in establishing the MENS project in North Dakota. Because administratively, rather than having to deal with every health system or hospital or clinic throughout the state that may be reporting health data, having to work with them individually to put in place data use agreements and take into account all of the HIPAA and privacy considerations. North Dakota is lucky that we really only need to deal with the the health data repository, or the NDHIN, that already exists. Another thing is, some background is that the NACDD will coordinate the development and implementation of the MENS project with 5 organizations that have experience working with clinical health data. Those organizations are the University of Massachusetts Medical School, Commonwealth Informatics, Harvard Medical School, Department of Population Medicine, the Public Health Informatics Institute, and the Council of State and Territorial Epidemiologists. And also, MENS, of course, has multiple surveillance implications beyond chronic disease, such as, infectious disease surveillance or injury surveillance, you name it. I can't make any promises at this point, but theoretically, I would think virtually anything that could be captured in a health record could be, aggregated and possibly accessible through this kind of a system. And finally, I'd like to tell you a little bit about some of the work that the North Dakota Department of Health and the North Dakota Health Information Network has already done with the MENS project. They participated in a MENS guidance group meeting in Atlanta with the NACDD and many other states back in March. And upcoming work for North Dakota on the project involves a demonstration of end-user interface systems. And those, of course, are very much still a work in progress. And we will be having an in-person meeting with representatives from the NACDD coming to North Dakota in August. So, it's beginning days. We're pretty excited about this project, and the North Dakota Health Information Network, I think the way it's structured puts us in a pretty good situation for moving forward on this project, and we're just excited. So that's pretty much it in a nutshell, and I'm just wondering if anybody has any further questions.
Hi, this is Barbara Gabella. I'm also at the Colorado Department of Public Health and Environment. I'm an epidemiologist here, and I joined 5 minutes late, but
okay.
I'm just really glad that you pointed out the Council of State and Territorial Epidemiologists, partly because I'm on their executive board, but
great.
also because they've been working with CDC to pilot a similar process for the conditions that must be reported to CDC. Now, most of those nationally notifiable conditions are infectious diseases, but they also are interested, both CDC and CSTE, interested in expanding for using that pipeline for injuries. And I can't tell if they're at the same stage as MENS, but they have 2 hospital systems in the U.S. reporting real time for the national notifiable conditions to CDC. So that that system is now active, but in limited capacity. And again, if you think about nationally notifiable conditions, those do need rapid reporting to CDC, whereas injuries is not nationally notifiable, and so it doesn't need this rapid pipeline.
Okay, well, that sounds really good too. I am a little bit familiar with what you're talking about because I am a member of CSTE, but so I have seen some of the communications back and forth on that.
Great. You do have one question from the phone or on the chat from Tracy. Have you identified any cons as it relates to this system?
I guess one thing that would readily come to mind for me is just that, there is going to be no one size fits all, because every state is going to be, have a slightly different situation with their electronic medical record or electronic health record systems. So it's almost like each state that wants to join this, though, is still going to have to do a bit of legwork to try to make it work in their state. And then, of course, trying to get it all so that it works in a national system. It's going to be a lot of work, basically. That's the first thing that comes to mind for me. Any other questions or?
Great, thank you so much. Always good to hear about a system that I'm unfamiliar with. So thanks for your presentation.
You're welcome. No problem. Like I said, it's something that I think it has great potential, but it's still early days.
Great, thank you.
And Mandy selfishly hopes that it'll mean something, you know, for falls as well as like traumatic brain injury. So once they do the stroke and heart disease stuff, hopefully they can add other conditions as well, and it will work in that respect too.
All right, thanks everybody.
Great.
Okay, and I think Dwayne was next on the list, if I'm remembering correctly, on the agenda.
Yes, that is correct. Dwayne, I have your, since you just had one slide here, I can pull that up for you.
Sure, that'd be great. And while Lindsay's doing that, first of all, hello everyone. Thanks for the opportunity to share some of this work we're doing. This is some work that I try to do in my spare time when I can find it, and it actually started looking at economic costs, gosh, probably 4 or 5 years ago. The genesis of this approach was we were fighting a bill in the General Assembly every year that would allow kids as young as age 10 to ride ATVs on designated county roadways. And the proponents of that bill, typically rural communities on the western slope of Colorado or frontier communities on the eastern plains, would say this is a local issue. And please don't promulgate rules from Denver that affect our way of life in these rural, often ranching communities. And since we don't have any industry in small towns, a lot of families rely on ATV outfitter operations to generate some revenue. And so I needed to find a rebuttal for that argument. So being a level 1 pediatric trauma center located here in Aurora, Colorado, we're the only level 1 ACS verified in the 7-state region up and down the Mountain West. We get the worst of the worst injuries flown to us from many, many states. So I looked at our trauma registry and wanted to know how many kids we had treated for ATV-related injuries and what the associated costs were, and then stratifying by payer source. And particularly I was interested in the Medicaid burden. As we all pay into our state Medicaid plans, that takes the argument from a policy perspective away from this is an individual freedom issue. Was able to demonstrate that there were significant costs associated with ATV injuries that were a burden on our state Medicaid and therefore our state budget, and presented that to the interim committee that was studying the ATV bill in the General Assembly. We were able to keep that bill away for another year. This is probably about 2 or 3 years ago. And then finally they, I think, outsmarted me and said, well, we want disabled veterans to be able to have access to recreational trails without reloading their ATV in the pickup and driving down to the next trailhead a couple miles down the road. So this is a good bill to have. And at that point, I didn't have a good answer for that rebuttal. So that bill eventually did pass. But in the interim, we've also taken this approach of looking at the financials to treat these injuries for teen motor vehicle crash injuries And then as you can see here, pediatric gunshot wounds. And just to close out that thought on the ATVs, not only we were able to identify the cost burden to Colorado Medicaid, but we also billed 15 other state Medicaid plans plus the Indian Health Service. So it was beyond even a state issue, it was a regional issue. And in at least one case, our hospital ended up writing off over $500,000 in uncompensated care because there was no insurance. It was coded as cash self-pay. Obviously, we can't do that very often, or we have to raise rates. So it does have a trickle-down effect. But transitioning to this particular research in the cost of pediatric gunshot wounds, we looked at every kid that was in the trauma registry at Children's Hospital Colorado and Denver Health, which is level 1 adult, level 2 pediatric trauma center in downtown Denver. And we initially looked at 10 years worth of registry data, but when we matched up the financials, we were only able to go back to a starting point of January 1st of 2013, and we ran the financials through September 30th of this past fall of 2018. So essentially how we did this, we pulled the medical record numbers from the patient record, or pulled the medical record number and then matched that up with the accounts payable bill in our financials. So what I wanted to look at was what did we bill for the acute care costs and subsequent rehabilitative costs for gunshot wounds? What was our actual cost, our institutional cost, and then what did we recoup? So 3 different variables. And of course, depending on your insurance, you know, the actual bill that we generate can vary greatly. It can be inflated, it can be somewhat fair dollar amount. So that's why it's important to look at what the actual cost was to institutions and then what did we recoup. So we could bill, let's say, $500,000. Our care may be anywhere from $200,000 to $400,000, but we may only recoup, you know, $150,000. So how do all those figures play into another to build a financial argument for consideration of the public health burden of gunshot violence? And hopefully take it out of the realm of the Second Amendment issue and put a different slant on the conversation with elected officials and show them that there are direct, real, cold, hard cash effects of something that is nearly entirely preventable. This was an IRB-approved study, which helped greatly when we were going to accounts payable. And even though they knew me and I had asked them for financial records before, you know, as a matter of due diligence, they're saying, what are you going to do with this data? And if I'm able to say, hey, it's an IRB-approved study, you know, just hand it over, that helps a lot, rather than, oh, we just want to see what the figures look like, because hospitals obviously are very protective of their financials, particularly as institutional cost goes and contributions to revenue or loss. So we ended up with 236 cases. And I'm not going to read through this poster slide, but I will direct your attention to the pie chart where it talks about gunshot wounds by intent. The majority were assault type injuries. Those typically are teenagers that are injured in violence or gang-related activities. The accidental portion of the pie chart, the gray piece of the pie there, 13%, those typically represent kids that were injured because they found or accessed an unsecured firearm and either discharged it themselves or accidentally the gun went off in some fashion. And you can see the relatively small percentage, thankfully, of suicides where a firearm is involved. We looked at a number of ways of kind of slicing and dicing this data, including mapping the data by zip code and by census tract. Unfortunately, the frequency counts weren't high enough to really inform anything on the mapping. We mapped it, and there was a whole lot of blank spots in the geography around the Denver metro area. And those were where there were frequencies, the heat gradients weren't significant, so it really didn't tell us much. We also considered stratifying by caliber of bullet. That information wasn't always available in the medical record, as that was commonly determined by the law enforcement reports. So what we did look at was the financials that I previously mentioned, and also the service lines that were involved at the hospitals. And I want to say there was about 18 different service lines or surgical specialties that were involved. And if you think about all that goes into activating care for a gunshot wound, it's everything from the blood bank to social work to pastoral services, obviously the surgery, to the operating rooms, the emergency department, and on and on and on. And that varies obviously where the wound occurs on the body. So I'll direct your attention to Table 1. The thing that I found really fascinating and surprising about the findings were that dental surgery was far and away the most common specialty that was impacted. And certainly if someone's shot in the face or in the jaw, that's going to be the case or the need to call in the dental surgeons. But I think it also speaks to the different projectiles, whether it's a blast type wound injury versus small caliber or large caliber bullet or what have you. Another thing we looked at was the incidence of massive transfusion protocols. So that is a complex process that is initiated when an injured patient needs blood, and they need it fast. And there are specific criteria for what's defined as a massive transfusion protocol or initiating that protocol process. But in a nutshell, the easiest way to think of it is if it's transfusing more than 4 units of red blood cells in 1 hour, when an ongoing need for blood is foreseeable, or another criteria is replacement of half of the total blood volume within 3 hours. So some of these kids with significant injuries to their vasculature, they're bleeding out as quickly as we can put the blood in. So until they get up to surgery and the vascular surgeons can repair the leakage, it's just a matter of, keeping oxygen-rich blood in their system to keep them alive. And I want to say the largest volume I saw in one of the records, we put in like 15 units of blood in one kid, and he was just, losing it through his abdomen as quickly as we were putting it in, but it was needed for other organs, organ support in other areas of the body. So when we looked at stratifying the payer source, and I'm looking at the results up top there, so about 2/3 of the cases were covered by Medicaid, where Medicaid was the primary payer. And note that there was a longer average length of stay for Medicaid kids compared to those with commercial insurance. So that speaks to probably a subsequent quality and process improvement investigation Not quite sure why that is. We didn't get that far in the study. As I said, we're a level 1 regional pediatric trauma center, so we get a lot of kids flown to us. Air ambulance transport is very expensive. That is a separate bill that's generated. It's not included in the hospital bill. That's a separate entity that generates that bill. And for those not familiar with those costs, if it's a helicopter, just to hit the ignition and turn the rotors on the helicopter, that bill starts at about $18,000. And in the same fashion as a taxi, they do charge by mile flown. So the further away they come, the more the bill's going to be. We do have 2 helicopters here at Children's. Anything more than 500 miles in transport is going to be a jet, what EMS would call fixed wing, so a jet plane, and that gets on up into the $40,000 range. So we are aware of a couple instances where kids were flown to us, and obviously that's insurance isn't covering that. They do sell supplemental insurance, but I don't know anybody that has that. But that is a crippling financial bill for a family, even in good clinical outcomes. And if the bill is relatively low for the acute care that's provided, that air ambulance bill can be a financial burden to families and have a trickle-down effect on their health and their finances for decades to come. You can see up in the upper right corner of the poster, most of the kids were male. Mean age was 14. Significant injury severity scores, about 9% expired. Almost half required transfusions. A very small percentage, 4%, required that massive transfusion protocol. Almost a third were admitted to the ICU. Obviously, those costs are higher per patient day and per bed in the ICU than in some other units. And you can see the average length of stay there. From the perspective of whenever we do research, we're trying to answer the question at the end. So what are you going to do with this? So you found out all this information. What are you going to do with it? And I have used this in conversations with elected officials to let them know that, again, this is beyond a Second Amendment issue. It's a healthcare finance reform issue at its, kind of terminal conversation. But if we're able to say to a particular elected official in the Colorado General Assembly, here's why this issue is important to your constituents, because they are disproportionately represented in this data, and oh, by the way, here's what it's costing families in your district. Again, that puts a little bit different slant on the conversation than the stereotypical, for or against gun rights. So as we progress, my goal is to basically replicate this process for every mechanism of injury that we have, or at least the major ones. And I will stop there and take some questions. And I'll add, last thing. So we also, subsequent to putting this information together, we did get the data user agreement squared away with Memorial Hospital in Colorado Springs, which at the time was a level 2. They're now a level 1 adult. So we will be adding some counts to this mix eventually, once we get to it. We have submitted this manuscript for publication. It will be presented at the American Association for the Surgery of Trauma meeting by a couple of our docs. I don't know, maybe this summer sometime that meeting is. So, okay, I'll stop there and take any questions. Thanks.
is Jeannie Beats in Nebraska. This is really good stuff. The thing that I had not, and I don't know if we're doing that here, is the actual, we based a lot of our costs off of what was billed versus, what you were saying about what was actually recouped. So how did you, what mechanism or what did you do to know what the hospital actually received back?
Good question. So that is all captured in accounts payable. So we'll look at a discharge year. We could do it by month for injuries that are more voluminous than this, but we can capture gross charges and then payments, and then they'll calculate a collection percentage, which accountants will characterize as contribution. So contribution to the hospital's bottom line to the profitability. We know the direct costs, and then they'll estimate a cost margin. So a cost margin is essentially the revenue that we get for providing the acute and rehabilitative care minus the direct costs. So what's our margin per procedure, per patient? And then they'll put this all in regular spreadsheets that service line administrators and hospital executives will see on monthly dashboards. Ultimately, this is most, what's the word I'm looking for? Most valuable information to the chief financial officer, so that we can see what service lines or specialties are doing in terms of profitability. We are a nonprofit hospital. However, we're also a business. Most hospitals, from a financial perspective, hope to achieve an annual margin of about 6% profitability. The payments are better for adult hospitals than they are for children's hospitals. So children's hospitals get reimbursed, generally speaking, at a less favorable rate than adult hospitals, where Medicare is a little bit better reimbursement than Medicaid. For perspective, our payer mix in the Denver metro area is about 47% Medicaid clients. That's actually pretty good. Many children's hospitals are in the 60% range. Interestingly, we just opened a hospital, a freestanding children's hospital in Colorado Springs, that has a huge military presence in the city down there. And our payer mix down there is about 25% TRICARE, which is military insurance, and then less, maybe 35% Medicaid down there. So different communities have different needs and different profitability and payer options. So again, it's important to make friends with your folks in accounts payable, or folks that are working in hospitals I'm referring to, and to get the IRB approval to access this information, because chances are if you don't have that IRB approval, they're going to stonewall you.
Thanks, that's great information.
Any other questions for Dwayne? Hearing none, I guess we'll move on. Thanks for your presentation, Dwayne. We can go ahead and have Sasha start her presentation.
Thank you. I'll just take a quick minute to share my slides. Okay. Can you all see these?
We can see them.
Okay, awesome. So today we're just going to do a quick overview of a data linkage we did to better understand immunization as a protective factor for sudden unexpected infant death. And before we dig into that linkage, Kate is going to give a quick overview of our system in general so that you understand a little bit more about what we do and how we do it.
So thanks for having us today. I know some of our partners online are part of our system, like Dwayne, or in the same branch, but we wanted to just give you a little bit of an idea of the work that we do in the child fatality prevention system. So we are Colorado's child death review process, and we review deaths due to violence and injury, or the causes listed there on the left side of your screen. On the right side, you can see an overview of our system. So we include multidisciplinary partners in our reviews. So all the cases of children who die in Colorado 0 through 17 are reviewed by these 43 local teams you can see represented there at the top. Then we have a 46-member state review team that's responsible for looking at the aggregated data from each of the individual case reviews and then making prevention recommendations. And then we have the team that Sasha, Andy, and I represent with the state support team, and we have some other colleagues as well at the state health department. But you can see that we have wide representation from different disciplines. We use a public health approach to this work, which just means that we use data to inform, to help us identify problems and risk factors as well as protective factors, and then develop and test prevention strategies, which we then implement and then of course evaluate. So this is key, I think, to understanding why it was so important for us to link with a system like SIS, which Sasha will talk about in a few minutes. And then just quickly, you've probably seen this before from Colleen or Lindsay, but we take a shared protective factors approach in our branch to our violence and injury prevention work. So we believe by impacting these 4 protective factors, we can see impacts in all of the outcomes that we care about. And this is true, of course, for the child fatality work, child fatality prevention work as well.
Okay. Awesome. So now that you know a little bit more about CFPS and the frame we use to guide our work, I'm just going to dig a little bit deeper into sudden unexpected infant death, or SUID, both nationally and in Colorado. So nationally and here in our state, the rate of SIDS, or sudden infant death syndrome, has been decreasing since the early 1990s, while the rate of SUID that's attributed to undetermined causes and accidental suffocation and strangulation in bed had increased. And improvements in infant death scene investigations, a more thorough understanding of these mechanisms, and the collection of much more detailed information about safe sleep circumstances have really largely driven the changes in these rates. But you can see in that top line on the graph that nationally the combined SUID rate decreased in the early 1990s, but has since plateaued, which prompts us to really promote and bolster the protective factors for SUID. So this figure shows the crude rates of death for child fatalities occurring in Colorado among Colorado residents under 18 years of age, and that were reviewed by CFPS between 2013 and 2017. So you can see that in Colorado, the SUID rate of 65.8 per 100,000 live births dramatically outpaces the rates of our other leading causes of death at 7-fold higher than the youth suicide rate. And because the SUID rate remains so high at a national level, the American Academy of Pediatrics developed several recommendations for an infant-safe sleep environment, really in an effort to help reduce the risk of SUID. And these recommendations include breastfeeding, avoiding alcohol and illicit drug use, supine or on the back sleep positioning, use of a firm sleep surface, and avoidance of soft bedding, among others. And although the availability of sleep environment data varies from case to case in our system, the real takeaway message from this figure on the slide is that none of the 228 infants who died by SUID between 2013 and 2017 met all of the American Academy of Pediatrics Level A recommendations for a safe infant sleeping environment. And one recommendation that's missing here that we haven't really been able to meaningfully track in Colorado in the past is that of routine immunizations for infants. And just briefly, there have been several decades of back and forth research on the association between immunization and SIDS. But up until recently, it's been some studies have found an association, some have not. But this meta-analysis is really highly regarded and was published and shared some summary results indicating that the risk of SIDS is halved by immunization. And so this regarded study really prompted the American Academy of Pediatrics to expand their infant safe sleep environment recommendations to include that infants should be immunized in accordance with recommendations of the AAP and the CDC. Which now brings us to why did we do this data linkage? So we enter all information about our cases into the National Center for Fatality Review and Prevention Case Reporting System, which is really just our web-based system for abstracting information about our cases. And we are able to collect a little bit of data around whether infants were up to date on all recommended vaccines at the time of death. So you can see on this slide that the two questions we ask are about if the child was up to date with immunizations, as well as if they had received a vaccine in the 72 hours prior to their death. And one of our local child fatality review team coordinators was trying really hard to find some information to complete these immunization related questions, but was having kind of a difficult time tracking down the information that she needed. So this local coordinator reached out to the Colorado Immunization Information System, or CIS, for the child's vaccine records, which was a really great strategy because CIS is our state population-based electronic system that consolidates all immunization records for Coloradans of all ages. And when CIS received this records request, they subsequently communicated it to us here at the state support team for CFPS, which really prompted us to look into our data quality around these immunization measures, and we immediately recognized that this was a great opportunity for a data linkage between our two systems. So as an idea of what our data quality looked like prior to the linkage, you can see here in this figure that 93.2% of our data was missing or unknown regarding if the infant was up to date with immunizations at the time of death. And this high proportion of missing and unknown was really largely due to just immunization data not being easily accessible in the context of child fatality reviews. And so after CFPS and CIS both realized that this would be an opportunity to link our data systems, the next step was to develop and sign a data use agreement. And from what I understand, this process took about to complete, but once the agreement was finalized and both programs signed off on it, we were able to really hit the ground running with this linkage, which brings me to some results, and I'll just share a few of the interesting things that came out of this data linkage. So we decided to link data for all of our SUID cases occurring in Colorado among residents between 2009 and 2017, which started, you can see in that blue box, as a cohort of 427 infants. And in orange, you can see that 381 of those infants, or about 89.2% of that cohort, did successfully match to a CIS record, and the remaining 46 cases did not have a matching immunization record. So then moving farther to the right in those gray boxes, you can see that 58.3% of those cases that did match with a vaccination record was not up to date with their vaccine schedule at the time of death. And just for a quick comparison, we did poll a group of infants from CIS that were born within the last year in Colorado and determined their up-to-date status on the date that we polled the data. And almost 55% of that comparison group were not up to date with their vaccines. So this SUID cohort with 58.3% not up to date was pretty comparable to the general population. So now that we had our successful data linkage and we created these two cohorts of infants that were up to date versus not up to date with vaccines at the time of death, we did a little bit of analysis to determine if there were any significant differences between those two groups. And among many variables examined, there were only two that had statistically significant differences between the groups, one being age, which you can see in this figure, which shows SUID occurring in Colorado among residents by age group and their adherence to immunization schedule. And you can see that the largest difference are in the youngest two age groups, which is essentially flipped between both groups, where almost a quarter of those up to date were within that 1 month age range, 0 to 28 days old. whereas only 5% of those not up to date were in that age group. And then the second significant difference between the two groups was by residence county type. And so this figure shows SUID occurring among Colorado residents by residence county type, rural, frontier, or urban, and their adherence to the immunization schedule. And we can see that there were double the proportion of infants living in a rural or frontier county among those not up to date compared to those that were up to date. So this could potentially speak to access to vaccines in rural areas. And then lastly, I just wanted to show this figure, which represents the number of vaccine doses that were recommended at the time of death. So we can see that, interestingly, 96 infants, or about 43% that were not up to date, were only behind by 1 dose. And then of the remaining infants that were not up to date, 28% needed 2 doses, 15% needed 3, and 14% needed 4 or more doses. So I just thought that that was an interesting point to show you all. And then when we were exploring other potential differences between the two groups, there were, like I said, no other significant differences between the groups in the variables that we looked at. And so this is a list of different things that we did examine for. We looked for differences by health insurance type, because we know that some physicians have a hard time looking and dealing with financing vaccines and insurance coverage for vaccines. And then we know that clinics, especially small ones, can find it burdensome to manage providing vaccines, including enrollment in different programs, billing insurance companies, and paying for vaccines, but there weren't any significant differences there. Also, according to some studies, nearly a quarter of doctors have stopped seeing patients because their insurers did not reimburse well enough to cover the cost of providing and administering vaccines. But again, there just wasn't anything different between the two groups there. So in summary, prior to going forward with the data linkage, only 5.6% of our had known information regarding their immunization status. But then after we linked with the CIS data, we now know vaccination status for 89% of our SUID cases. And to us, this is just a huge success in and of itself, being able to leverage the two data systems and have such a great improvement in our data quality. And then since we now have access to reliable and consistent data on immunization status, CFPS will definitely be better able to understand the impact of immunization as an important protective factor for SUID. And our hope is that with every year going forward, we'll be able to maintain this data linkage with CIS and keep building our immunization-related data to be able to inform prevention by developing initiatives to bolster immunization rates and really educate the public on the protective effect and the importance of vaccine compliance for SUID prevention. And then really quickly too, after this successful data linkage, we're already planning another data linkage with our partners at the Newborn Screening Registry here in Colorado. One of our critical variables for understanding SUID is around abnormal metabolic screening results. And so our hope is that we'll be able to really improve our data quality on that measure as well with another data linkage. So if you have any questions, feel free to ask them now, or you can always feel free to email me.
Hi, this is Celeste from Nebraska. I was just wondering if you could talk just briefly about your linkage methodology.
Sure. So we provided, we were the data giver, and CIS really took our data and they performed the linkage. So we provided them with a data set of all of our SUID cases between 2009 and 2017 that included some unique identifiers that they could match on. And then CIS staff performed the linkage and gave the final data set back to us. It was mainly the birth certificate number and then some other things that they could check on just in case they didn't have an immediately successful match.
Thank you.
Yeah.
Any other questions for Sasha? Okay, great. Thanks for your presentation. And then I know that Lisa had some information that she wanted to share as well.
Well, thanks, Andy. Sorry. I think in the essence of time and being respectful, I just wanted to share a couple of unique data sources that we've used, and then I'm happy to talk offline with somebody if they're interested in. We tend to use some justice system data for some of the violence and injury work that we're doing through the Injury Prevention Research Center. I'm just going to give 2 quick examples. I won't even use slides, and then I'm time and space for other discussion or questions. But we have been very successful in working with our Department of Corrections as well as the Department of Human Rights to access the corrections data and take a look at like Iowa's Batters education program. We've also used it to look at some youth offender information and processing that system. And then also we're looking at an evaluation of youth placement programs based on adverse childhood events using corrections data. So it's kind of just another unique data source that you may not have considered in your violence and injury work. We are also using some of the corrections data or justice system data to inform our traffic safety projects as well. And again, that's all I'll say for now, because I thought the other presentations were fantastic representations of unique data sources and how to do some interesting data linkages. But would be happy to share more on our findings and specific projects if anybody has interest in those types of data sources. Thanks.
Thank you, Lisa. Does anyone have any questions for Lisa? Okay.
Lisa, do you have any kind of finished products from analyses using these data systems that we might be able to share with the group? Because I'd be happy to do that.
Yeah, absolutely. I will send you some of the slides I was going to share and just a couple of maybe like report types of things that show how we use the data and what were kind of the results of it.
Great. I think that'd be great.
Thanks.
Okay. We'll wrap up then. I guess our next meeting is July 22nd. I believe it is 1 p.m. Mountain, 2 p.m. Eastern, so the same as last time, and I believe it's also a Wednesday. Is that correct, Lindsay?
Didn't look at the specific time. Sorry, calling the scheduling. Let's see. It's actually a little earlier, so it'll be 10 a.m. Mountain Time and 11 a.m. Central Time on the 22nd.
Okay. Thank you. And then what was the topic again? I'm sorry.
No, that's right. The topic is going to be integration of injury and violence prevention with other units of government. So if any of you have great examples of where you have, really collaborated across state agencies or other government entities with universities, etc., we would love to get some examples. Carol Runyon and I are slated to kind of plan that session, and so we might be reaching out to some of you as it gets a little closer for some examples to feature.
Great, thanks, Lindsay.
Great. And I see that Tracy is saying she would be interested if there's been any tribal work coming on and related to what I just said, and I do think that would be a really interesting opportunity, and just saw that there's going to be a tribal conference in Denver coming up in July, so certainly encourage all of you to attend and try to get out here if you can. We're planning to have some people there for sure, so that was an exciting thing to see this morning. I just wanted to, last minute, we have to do a little plug. As I think many of you know, I'm the current president of the Safe States Alliance, and Lisa and Jeannie Dietzer and Peg, we're all very well represented on the executive committee, but we are trying to recruit new executive committee members, and the deadline to apply is coming up this week. So if you are interested, I'd be happy to talk to any of you in the positions. We have a treasurer position, a secretary position, and 4 member at-large positions open. And I hear that applications are a little slow to trickle in. Sometimes we get things the very last day, but if you are thinking about it, please let me know, and I'd be happy to chat with you more about what you would be getting into.
Thanks, Lindsay. I was just going to add about that tribal conference that's in Denver. I do know that the registration is limited. The tribal contact that we have said it was limited to 250 people. So if you're interested, register soon.
Great. Well, thank you, everyone. Have a great rest of your day. Thank you, Mandy, for facilitating. Bye.